Vijayakumar. Dr. Vijayakumar has over 20 years experience in critical care, and he is an anesthetist by his clinical profession. In addition, clinical nutrition is his area of interest, and in that he holds the position of president of IAPEN Tamil Nadu chapter. He's the chairman of the Hospital Nutrition Steering Committee of IAPN. He's also the honorary physician to the honorary His Excellence Governor of Tamil Nadu. He's acknowledged as an expert in not just anesthesia and critical care, but also nutrition, and holds a distinction in microbiology and anatomy. I have a whole page with his accomplishments, Dr. Vijayakumar, but suffice to say that as a president of the Tamil Nadu chapter of IAPN, he's become a mentor to many in the organization, and I welcome you to come and deliver your lecture.
Thank you very much, President, for giving me the introduction. And respected chairpersons, the delegates, it's my privilege being in front of you in this conference to deliver the lecture on the topic, Critical Care Nutrition in Sepsis. We all know the infection will sets in, even in burns, even in trauma, in any other clinical conditions. But there are factors which influence the overall risk of infection in any given patient. So the dose of microbial contamination is the big factor which is responsible or increasing the risk of people getting infection. So the dose of microbial contamination can be controlled by the infection control measures like simple hand wash and so on. And if the bacteria is virulent, definitely the risk of infection increases on the patient, and the virulence of the bacteria can be curtailed by antibiotics which we are using. But we don't have much in our hand to counteract the resistance of the host against all these infections. How to improve the resistance of an individual to overcome these infections is a big challenge for us now, today. So if you look into the evolution of clinical nutrition also, it started as hyperalimentation, total parenteral nutrition long before. And then we realized the enteral nutrition and the early enteral nutrition is going to help the critically ill patients. Then we moved on to that stage. And we realized we cannot give adequate calorie to our patients with a single route. So we have to have a combination of enteral, parenteral, or enteral and parenteral together. So that is called combined regimen, and that we practiced. And now it is an era where we moved on to the immune modulation or immune therapy on our individuals. So this is how we evolved in a clinical nutrition practice. From the passive supportive care, we used to call as nutritional support to the patients. Now, when we realized that nutrients can modulate the inflammatory responses and improve the patient outcomes, now it become nutritional therapy or pharmacotherapy, and that is where we try to use some nutrients to improve the resistance of an individual to overcome the infection on them. So I'd like to give you the historical parallel here. In the year of 1740 to 1744, the Lord Ansons had an expedition around the globe. In his voyage, he had 1,317 deaths, and 75% was directly attributed to scurvy. Dr. Lin proved citrus fruits are the treatment, but at that time people never believed the simple solution can solve a big problem, and it took 40 years for the British Navy to accept the truth, because James Cook and his commanders could not accept the simple option and working on more complex nutritional and physical management. They never accepted this as a treatment. 1795, Nelson Navy used lemon juice on all the soldiers, and they had a success in the 1805 Battle of Trafalgar. Lime juice was introduced as a cost-cutting measure instead of lemon juice, which contains only 1/3 of vitamin C in the Navy, and the British sailors end up in having a more mortality in their voyage, and the British sailors were given the nickname limeys by the US sailors, scurvy recurred in the long voyages. So simple solutions can also be a problem solving in a big problems. The same historical parallel can be applicable in case of systemic inflammatory response syndrome. Trauma, burns, infection, whatever it may be, anything which stimulates the inflammatory response syndrome, we have two options now. One is the glutamine and omega-3 fatty acids, which can improve or modulate these inflammatory responses on individuals. Just look into the glutamine turnover in a healthy individual. This is the vascular glutamine pool. You can have the value of glutamine in every patient. So this glutamine pool is coming from the muscles, lungs, and the liver into the blood. But the glutamine is utilized by the kidneys, intestines, and the macrophages, lymphocytes, and erythrocytes. This is the balance happening in a healthy individuals. Let us see what happens when the individual is put into the systemic inflammatory responses. From the vascular glutamine pool, the macrophages take the maximum amount of glutamine, and the intestine takes more, kidneys and liver, everybody started taking more from the glutamine pool. So end up in having a glutamine deficiency in a stress individuals. So the critical illness is associated with lower levels of glutamine always. That has been proved by various studies in various clinical scenario. If the plasma glutamine depletion is combined with that of the Apache scores, if these two things are there on a patient, the chances of mortality is increasing. Low glutamine and high Apache score in a critically ill patients end up in having an increased mortality. So by giving glutamine, what are the things which we can achieve on our individuals? In a critical illness, glutamine pool coming down, and we are giving glutamine therapy to the individuals, the beneficial effects are, it increases the nucleotide synthesis and becomes the fuel to the enterocytes, so that the maintenance of intestinal mucosal barrier happens and the translocation of the bacteria is nullified. So this is what we used to observe in a stroma, in systemic inflammatory response, where we are not able to provide them the adequate calories to the enteral route. When the patient is put up on nil per oral orders, the translocation of the bacteria is the major problem on them, end up in having multi-organ dysfunction syndromes. By giving the glutamine therapy to them, we can bridge the gap by keeping them the NPO. At the same time, we can protect the mucosal barrier and try to prevent the translocation of the bacteria on them. And the same glutamine becomes fuel for the lymphocytes too. And that's how it maintains the lymphocyte function and able to reduce the infectious complications. Glutamine gives glutathione. It's a free radical scavenger and decreases the free radical availability. And it becomes anticatabolic effect, so the individuals can preserve their body mass. And more importantly, now the research has proved the glutamine therapy has increasing the heat shock proteins in the patients. And you all know in the septic patients, now we are doing extracorporeal circulation and trying to filter out the cytokines. The cytokines filters are available now. Instead of having so much of sophisticated things, by giving the glutamine, increasing the heat shock protein, they can nullify the cytokine. Attenuation can happen so that it will prevent the multi-organ dysfunctions on them. And it preserves the transcellular actions. It increases the interactions between the two cells by giving glutamine. And most importantly, it enhances the insulin sensitivity. We have the problems in a sepsis or any stressed individuals having a hyperglycemia in them. So glycemia is increasing. Hyperglycemia is due to the insulin resistance, and that resistance is taken care by the glutamine therapy. So there are humpty number of beneficial effects by giving the patients on glutamine. That has been proved by various studies. Either with the parenteral route or through the enteral route, glutamine can give a good results. And it reduces the mortality to the greater extent of 32%. So the dose of glutamine, it's available as dipeptide. The combination of alanine and glutamine, 0.3 to 0.5 grams per kg per day is the dosage, and it should never be more than 30% of the total protein intake. But remember, when you are giving glutamine, you should not exceed the dosage. If you give more and more, the problems are coming up. So high dose should be avoided. And in a renal failure patient, especially when they are on the dialysis, try to avoid glutamine. And a shock individual, unresuscitated patients, try to avoid glutamine. The correct patients who are benefited by the glutamine are the parenteral nutrient patients. Whenever you prescribe TPN, you cannot omit glutamine. And burns, trauma. These are all the places where you can utilize glutamine. And coming to the infection and inflammation part. Infective organisms enters in the body and then we call it as infection. And to fight against this infection, the inflammatory system starts functioning, then we call it as inflammation. Trauma, surgeries, burns can also stimulate the immune system and it becomes inflammation without infection. Remember, it is the inflammation and not the infection kills the patient. We all think that the bacteria is killing us. It is due to the inflammation, overwhelming inflammations of our own immune system that kills the patient. Infection, we do have a control. But inflammation is not yet under control, causing high mortality in ICUs. If you look into the infection and inflammation sequences, the moment you get infection or the trauma or thing, initially our immune system is stimulated and that phase is called systemic inflammatory response phase, where you'll have immune mediators are coming up in a larger amount and that is called sepsis induction. Increased generation of inflammatory mediators like tumor necrosing factors, interleukin 1, 6, 8. And everything will come to a halt once particular stage, and that stage is called compensatory anti-inflammatory response. Burns, you will have a systemic inflammatory response stage, and after a week or so, the patient will be pushed into the compensatory anti-inflammatory response syndrome. So if you look into any cells of our body, it is a bilipid layer. And in the bilipid layer, you have lipids, and the lipids you can group into omega-6 group and omega-3 groups. Omega-6 groups are coming from linoleic acid, and omega-3 is alpha-linoleic acid. And omega-3 is an anti-inflammatory precursor, so it will produce anti-inflammatory materials more. So we need a balance between omega-6 and omega-3 all the time in our body. By providing more of omega-3 fatty acids in us stressed individuals, it increases the levels of omega-3 fatty acids in the immune mediating cells, like mononuclear cells, neutrophils, and platelets, and end up in having a change happening in the phospholipid contents and reducing the productions of pro-inflammatory mediators, and anti-inflammatory mediators are more in our body so that we can counteract. So the dose of omega-3 oil is 0.1 to 0.2 grams per kg, 70 ml to 140 ml per day in 70 kilogram individual, and 10 to 20% of the total lipid intake. And make a point, it's a dose-dependent response, not like a glutamine. If you give more and more of omega-3 fatty acids, the more and more beneficial effects on them. Interestingly, if suppose the omega-3 fatty acids is given in the stage where the patient is on systemic inflammatory response, we have a beneficial effect. We have a control of pushing the patient from the hyperstimulation to that of less stimulation. But remember, if after a week of a burn, if you're giving them the omega-3 fatty acids where they're already on the compensatory anti-inflammatory response syndrome, these omega-3 fatty acids can produce immune paralysis. That is what we expect. But it has been proved by Heller, at whatever stage it may be, if you give the patient omega-3 fatty acids, it producing a balance on them, and that is the stage where it is called modified antagonistic response syndrome, called MARS. So by giving omega-3 fatty acids, you can balance your patient's immune system, and you can keep your patient always in a condition which is called modified antagonist response syndrome, and that is more beneficial for the patients to counteract the immune responses. So hence, in case of sepsis, the nutritional support, you should not be with calories alone. You should think beyond the calories, like immune modulating drugs. And finally, coming to the proteins, the importance of proteins in a sepsis patients. In case of starvation, what happens in our body is the carbohydrate exhaustion happens and followed by the fat. and late only the proteins. That is the regular starvation events. But the moment the patient is catabolic, like sepsis, surgery, stroma, whatever it may be, we are switched to the other area, our metabolism started functioning differently. And we don't know which makes this difference. What is the key? Changes these particular events in our body, that's the research is going on, and the people are now pinpointing the immune mediators and factors which is changing this physiology in our body, where the carbohydrate exhaustion happens first, and immediately before the fat, we start losing our own proteins. So the early protein catabolism is the commonest thing which we'll see in CIRS patient, inflammatory response patients, and all critically ill patient can lose as much as 1 kilogram of lean body mass every day. Every day we started losing, the critically ill patient, 1 grams. So the lean body mass loss is the main problem in critical illness. And if suppose they survive and goes to the society, the intensive care weakness, they are continues to have that. So we are producing not the survivors, and finally we are pushing them as a victims in the society. So how to control over it? 50% of the patients not back at work even in 1 year. And 33% of the patients never return to work at all. So that is what the patients we are producing by giving a good quality of critical care, reducing the mortality, but pushing the people with a reduced quality of life. Exercise limitation and reduced physical activity even persists for 5 more years after the ICU discharge. More than 40% of mortality at 12-month follow-up occurs on the post-op ICU discharge. 50 to 70% of people never regain the cognitive functions, and 60 to 80% having a functional impairment. So the nutrition therapy in sepsis should focus on these proteins. By giving more and more of proteins, when they are in a critical illness, you can nullify all these problems which happen after the discharge. So sepsis is characterized by early massive catabolism, lean body mass loss, and escalating hypermetabolism persisting for months to years. So the high protein diet is very, very important. The extra protein reduces mortality, and every additional 30 grams per day of protein given mortality decreased. And increased protein improves physical function post-ICU. So our septic patient should come strong, or otherwise don't come at all. To produce strong individuals into the society after critical illnesses, we should focus on the high protein diet. Thank you.
We will take questions after the next session. Thank you, Dr. Vijay.